First of all, I'd like to welcome everyone. Thank you for taking the time to join us tonight for this talk with Dr. Pratt and Dr. Imlah. My name is Derek O. I'm one of the co-founders of Zio Plus. And just a couple housekeeping rules. Obviously, no one has their video or mics on. If you have any questions, feel free to enter them into the chat or the Q&A box. We will track all the questions and we can ask the doctors and the presenters at the end of the talk. We'll save about 10 to 15 minutes for Q&A. After the talk, we will be doing our standard raffle for the 2 Amazon gift cards. And if you're interested in staying after, we'll do a quick 5-minute presentation on the products that Zio Plus has with Utiva and Ferrosome. So without further ado, I will do a quick introduction for our speakers tonight. We have Dr. Imlah, who is a family physician who completed her BSc, MSc, and MD at the University of British Columbia. She served as a medical director for a health foundation with over 42,000 clients and operated her own integrative medicine clinic, and also worked in the urgent care and ER setting. Her primary focus has always been on overall wellness and the prevention of chronic diseases. Dr. Emily Pratt completed her naturopathic medical training at the Boucher Institute of Naturopathic Medicine. She started in private practice and then began working with the Pure North Synergy Foundation. She has practiced integrative, evidence-based medicine for over 14 years and focuses on women's health areas such as fertility, contraception, and functional psychiatry. And without further ado, I will pass it over to the both of you.
Thanks, Derek. Thanks, everybody, for joining us tonight. The first couple slides are just exactly what was already introduced to you. We really appreciate your time. We know that we're all busy, and by the end of the day, we're all ready to be at home and doing something other than medicine. So just a few disclosures. This presentation is a bit different than possibly some of the other ones you've been to. This is all based on our clinical experience and not meant to supersede any of the standards of care. For those of you that are apparently attending from the US, we have a publicly funded system in Canada, so sometimes we talk about that within this discussion, and it might look a little bit different down in the US. As always, use your own judgment.
And that being said, I primarily work within a private pay system, a bit more similar to perhaps what happens in the States with the NDs there, where Dr. Imlah primarily works within publicly funded, but has also worked in private pay. So we will talk about the differences, and not that it's necessarily a difference of standard of care, but it's just where the standards of practice change between publicly funded and private.
So the only conflict of interest we have to discuss is that we're receiving an honorarium for this talk. So my goal, as I always have on any talk, is really to give you something that you can take back to the office tomorrow. So wherever that office is, whatever that office looks like, hopefully you can take something out of this. We know that we have a broad spectrum of levels of training. So some of this talk is going to actually be reviewing iron, how it's absorbed, what that looks like. So for those of you that are totally up to date on that, you might find that a bit boring, but just so we all understand.
Yeah, for those of you that have a background in this, perhaps you can finish your day-to-day charting, but we wanted to make sure, well, that's what we do when we sometimes do these things, but we wanted to make sure that, given from our last presentation too, that we're all kind of going on equal playing fields, and that also it's not to really have the discrepancies between naturopathic, functional, integrative, but iron deficiency anemia, what are the most up-to-date practice standards? What are the different options? Because it's also, when we're all busy with practice, easy to kind of fall into your top 1 or 2 choices that you use. But now there's different products on the market. There's different standards for doing parenteral iron. And we want to just give you the information that you could potentially use tomorrow in practice.
And we do both actually work together as well in a functional medicine clinic. So it is kind of fun to be able to, for me, being able to know what I do when I work in maternity and how I approach anemia there, and then how I might approach it here in integrative clinic. I think in the US, you probably have more integrative clinics than we do up here in Canada. But we've both been doing functional integrative medicine for a long time. So what are we going to talk about tonight? It's really about iron deficient anemia, specifically that. We're not going to delve too far into normocytic and macrocytic anemias and all those causes, although we will review them a little bit. So what exactly is iron deficient anemia? It's where the body lacks enough iron to produce hemoglobin. As I'm sure most of you know, hemoglobin lasts approximately 120 days. Our bone marrow is spitting it out all the time, and to be able to spit that out, it needs storage of iron. So, and hemoglobin, of course, plays such a big role in transporting oxygen in the blood. So what are the causes? Inadequate iron intake. It is a very, very common cause right across the world. Dietary intake varies in a lot of countries where there is no fortified iron cereals for children, where women who have multiple pregnancies back to back, versus people who have the standard American or now Canadian diet of fast food. And so you can often not get enough intake. There's times where people have increased iron needs, so pregnancy, growth spurts for kids, cases of blood loss, so GI bleeding, disease states, menstruation, obviously, and then malabsorption. And I think this is really an area that worldwide, we're starting to understand more and more about gut health. It was something that in functional medicine, we talked a ton about, even 15 years ago, but other people would sort of look at you strange and say, well, why do you think gut health is important? And as we learn more and more about that, the irons that we use, how they absorb, plays such a big role. So we're seeing more and more celiac disease. We have more and more bariatric surgeries, and then more just general bad gut health from diet. So it's actually quite I don't know what it's like in the US or in other provinces, but here it's a bit of a controversial topic right now. And specifically because the criteria is different from province to province. So many of the oral irons are really poorly tolerated. They take several months to get improvement. And so patients now want their options. And under the publicly funded system, they used to get that as an outpatient in ambulatory care in most hospitals. But they've removed that because our system can't afford to be paying for it. So especially when people could, maybe make some modifications to their dietary intake and supplementation and be able to get their iron up, it just takes several months. So that cost has now been placed over to the patient, which can be pretty hefty depending on if you have to go over to IV iron, but the demand is still there. So, and we're getting more and more products on the shelves. And so this is really creating, as public knowledge increases, people want more information on iron deficiency, people are demanding more care regarding anemia. We're creating more and more demand on our family physicians and naturopathic physicians here in BC, and people want these options. And so physicians are really torn on, should I give people IV iron? They can have one dose and be fine. Why are they not tolerating the oral? Do they just forget to take a tablet? Is that really a reason to increase the risk and have an IV? Those are all questions you have to ask yourself as a clinician. Do you have anything to add?
No, I think it's also too, we're going to touch a bit on the differences in treatment protocols. If within our publicly funded system, it's wonderful we live in a country that we don't worry if we can afford to go to the hospital if we need to, but it's also in some ways like in your car fixed on warranty, where our system is dealing with so much acute care and managing so much disease that unless you're really deficient, we can't necessarily do anything other than maybe some oral supplementation. So that's where within the private models that we're following most up-to-date evidence from other areas, where if it's reasonable and safe to do an intervention before someone's at potentially the quote unquote like critical level or the area that our publicly funded system would stay.
So I just wanted to review a little bit about iron. There's two types of dietary iron: heme based iron, which is available in the meat, the seafood, poultry. It's got variable bioavailability, somewhere between 15 and 35%. The non-heme, so plant-based and fortified foods, bioavailability is about 2/3 that of heme, but there are many people who don't want to take a meat-based or heme-based iron. And we have more and more vegetarians and vegans. And so it's nice to have these options. Those sources classically are the beans, nuts, dark green legumes. The absorption of most dietary iron occurs in the duodenum and proximal jejunum. So this is specifically because that's where you have the best pH that allows the absorption of iron. So iron comes in two forms. Classically, it's in the ferric form. When you eat it, it is insoluble and you have to convert it over to the ferrous form. That conversion requires a low pH. So the other one that we see more in the oral supplementation will be the ferrous form. That's soluble and that is also absorbed in the same place, which is typically along the brush border of the villi of the gut. So super important, these gut enterocytes. Once inside that enterocyte, once it's converted to a ferrous form, it can be either stored there or it can be transported out. That storage is ferritin. So that ferritin is like a sphere. It's got 24 subunits under it. It exists throughout the body. So macrophages have it, the enterocytes have it, and the hepatocytes have it. So it's not always just stored in the liver. And that becomes really important when we start talking about inflammatory disease process. So when it's transported from the base membrane down into something called ferroportin. It's super important. We are the only ones, it's the only known transporter in mammals. It's highly regulated, and inflammation leads to the high hepcidin levels, and hepcidin and ferroportin work together. And so when we have really high hepcidin, the ferroportin stops being able to grab onto that iron and shift it through the plasma, and it shuttles everything to our ferritin stores, and it makes it unavailable because it's just sitting in there without being able to be then re-exported out into the plasma. So we're seeing more and more anemia resulting from this because we have so much chronic disease that's inflammatory in nature that we're getting really high hepcidin levels. Those levels are degrading that beautiful brush border of our gut, and it's all sloughing off, and then we're releasing it all into our feces. And of course, with that enterocyte also goes the macrophages and other things, and the iron that's all in it. So some symptoms, these are, kind of feel like these are a little bit like thyroid, right? Kind of vague sometimes. Fatigue and weakness, headache, dizziness, shortness of breath. Often you see not shortness of breath as much as the loss of exercise tolerance. People will say, I go up a flight of stairs, I can't quite catch my breath. Brittle nails, which can be more common in some of the normocytic and macrocytic anemias. But pica and the pagophagia, so that real desire to ice, for ice and eating ice, really common in the iron deficiency. And then the restless legs. So it's always part of your differential if somebody comes in and complains with restless legs. So for those of you who don't order labs routinely, what do we order? So I put a CBC. This is a CBC that I would order here in Kelowna. So I just write CBC and all these variables are done for me, including an auto differential. So most hospitals now and most labs will do an auto differential of the white blood count. And then if anything is picked up by the AI that they work with, then the pathologist will do a blood smear and take a closer look. We usually order a serum ferritin. It's the biomarker of our iron stores. And then some people like to order the transferrin saturation, which just evaluates how much the bone marrow can access to make new hemoglobin. So ferritin is kind of where it's all at right now. Pretty inexpensive test, anywhere between $5 and $8, biomarker for our iron stores. But it's interesting that each province has a different criteria for iron deficiency. So Ontario has just made all sorts of headlines that in September of 2024, they're working with a hematologist who's gotten pretty aggressive about iron deficient anemia. And so their criteria is now a ferritin of less than 30. Now, for those of you in the US, I think it's equivalent, but I could be wrong. So less than 30 for an adult, less than 20 for children. And the government of Canada is the same. But here in BC, we say probable iron deficiency between 15 to 50 and likely iron deficiency less than 15. So a little bit different. In our maternity clinic, we usually say less than 20 is considered, a ferritin less than 20 is considered iron deficient. I really like this slide because this is really the gestalt of medicine looking at, because anybody can just follow numbers, but really understanding the process that's going on is super important. And so we talk about the stages of iron deficiency. We can all pick up iron deficiency when we're at the anemia and it's microcytic and hypochromic. All the reports come back. It's really obvious. The patient has the pallor, right? The gums are white. They're saying they're short of breath. They're not thriving. That's really obvious. But where do you pick in the middle there to start somebody on oral iron? Especially when they have a new diagnosis of a problem, you know that it's going to lead to some loss of iron. Where do you start? So if you think about it, the iron stores in normal should be nice and high. When those start to go, everything will feed out of those iron stores, out of the liver, the macrophages, and the enterocytes. Slowly, once that storage is gone, then it's going to start moving to what's being transported, floating around in the plasma. So when they eat, and there's anything floating around, it's immediately going to try to be used by the bone marrow. And then you're eventually going to get to the point where there's nothing left floating in the plasma, and that's when we're at the end point. So we really want people to start picking this up when they start thinking that there's the possibility we're going to have the low iron stores. Where's the problem in that? Well, high iron stores are a problem too. So this is where, some things are really obvious, but it is good to get a sense of where somebody is. I think this is going to be an issue, certainly here in BC. Our pharmacists are going to be able to prescribe without, off of blood work or just on their own for minor illnesses. And this is really where this gestalt's going to have to be put together, right? We don't want to start throwing somebody's iron super high. It's high inflammatory, it's hard on the liver. And so really important to sort of think about where your patient is within this process. Because sometimes their numbers might be fine, but they might have symptoms. You're up.
Okay. Well, yeah, I kind of think of iron deficiency anemia I like to use analogies because it makes it more applicable to patients and even for some people's, like my own understanding at times. So I always think of ferritin as like your bank account for iron. So your bank account, how much do you have stored? Whereas hemoglobin hematocrit is more like your debit card. It's your day-to-day spending. So when we're looking at intervening with people, it's wonderful what Ontario has done with the work of the hematologist. I'm sorry, I can't remember her name right now. But why wait for someone to be at the point where, like in BC, if your ferritin goes less than 6, we're supposed to report it to ICBC, which regulates our driver's licenses because you're at risk of passing out. Although none of us will do that because it's a pain to get your license back, but it's also why are we waiting until that point to intervene? So then also on the topic of ferritin with inflammatory conditions, as Dr. Imlah mentioned, is that we can also store too much of it. So there's times with like going into a bit of a rabbit hole of like a rheumatoid arthritis patient, if they actually look like they have too much iron in your ferritin, you want to look a bit deeper because it could be a false marker of inflammation. Or for the people that actually get too much iron, they can actually rust from the inside out. They have an increased risk of heart disease, diabetes. So that's why when we're considering using an oral iron or a parenteral iron, it's not just more is better, it's you have to be thoughtful about it because there's inherent risk with having too much. And even with the risk factor to liver or folks with hemochromatosis, there's different interventions for that. But looking towards the transferrin saturation, why Dr. Imlah brought that up, is I always think about it as kind of like passengers on a bus. So where are we in the bank account and how many people are on the bus at this point?
I think one of the things I just want to add in is that iron deficiency anemia is not typically something that happens overnight. So we see people, I see women in second trimester, third trimester pretty regularly when we repeat their iron or their ferritin, and we see ferritins of 4, 3. We're sending them for IV iron, but they got there gradually over months and months. Women who are menstruating, women who are, perimenopausal and having super heavy flow, they get there slowly. They kind of recover in between and then it goes again. So people's tolerance for it is much different than if you are a trauma victim and you lose a few liters and your hemoglobin drops down to 40. That's a very different person than the chronic slow release and using up of your iron stores.
And that's important to mention too, because it is that kind of frog in a boiling pot of water. Or as I said to a patient today, it's interesting what the universe gives you. Like, I have lots of iron deficient patients today and chronic disease, but just because it's common doesn't make it normal. Because for perimenopausal women or menstruating females or different demographics, just because it's common to have low iron stores doesn't mean it's normal pathology to have that. And then also I want to bring up about the elevated ferritin, or for folks with too much iron, is that it's interesting in a lot of pathologies, the symptoms of having too little could be similar to those of having too much. So often with people with more hemochromatosis can present with pains, fatigue, hair loss, shortness of breath. So if anyone that's ordering blood work to look at iron deficiency anemia, more or less just don't go off the ferritin, look a bit deeper too, because there's a bit of a story to be told with that. So, but risk factors.
Oh, sorry.
How do we go back?
There you go.
As Dr. Imlah works a lot with women of childbearing age, we menstruate, we grow babies, infants and young children. So there is increased risk of iron deficiency anemia in babies of sections. So you could probably speak more to about delayed cord clamping, but also through the diet of young children, what type of early interventions they've had. I know there's going to be some comments about the vegetarian and vegans, because there's a lot of ways that you can get a lot of heme or non-heme source iron. And really what it comes down to is how we produce food and how we digest it nowadays. I tell folks almost daily that we live in a time where never in our human history have we had such easy access and abundance to food. Historically, we didn't kill an animal every single day. And now there's the carnivore diet or the vegan diet, the vegetarian diet. There's all these different ways of eating, but yet we see these common deficiencies. So we look at the production of food. We also look at the digestion of it. So not many of us follow more Mediterranean styles where we actually take 2 hours to have lunch and chew it and make sure our stomach acid is nice and healthy. But also a lot of our deficiencies, there's research around even dirt, like not just from how fast we grow things, but we're not eating dirt anymore, where we used to get more microbes to support our gut microbiome to absorb our nutrient production and absorption. And then, of course, individuals with chronic disease. Iron is something that we use for fuel. We use it to move around oxygen. So if you have a disease state that requires more energy to burn, you're going to use up more iron stores. Or I've often used the analogy too of I work with some professional athletes, and when a man is low in ferritin or iron, it's like, where's the bleed or what's the cancer? Like, it's usually more of a 911 situation. But, for the amount that their bodies exert, I joke that the only reason I would do that is for like $4 million a year. Like, their amount of workout and turnover and iron store needs drastically increase. And same with chronic disease, even if it's not a malabsorption chronic disease state. So treatment options. I always tell people, irregardless of the condition, there's always an option to do nothing. We are in charge of our own bodies. But dietary changes. So increasing iron-rich foods. Of course, majority of people know that there's heme-based sources, but not everyone wants to eat meat-based sources. But I do have seen people that have a carnivore diet but still get deficient. And again, it boils down to digestion. But iron-rich foods, there's a slide coming up on each one of these. One of my favorite interventions is to encourage cast iron cooking, or products like the Lucky Iron Fish. There is oral supplementation of various states of ferrous salts, ferric salts, then you liposomal forms, which are pretty exciting and fun to use. And then also with regards to treatment options, being a naturopathic doctor, it's not always just about the what, it's the why. So if someone's low iron, we give them iron. But also, why are they low? Is there malabsorption? Is there digestion issues? Is there menorrhagia? And then the last treatment option is also parenteral iron, which I do in my office, both monoferric and venifer, and I'll speak a bit to each of those. So heme sources, animal-based products of iron. Of course, we have red meat, beef, lamb, pork, poultry options, chicken and turkey, and seafood, fish, salmon. Non-heme sources, legumes, nuts and seeds, especially this time of year. I'm a big fan of telling people to eat pumpkin seeds because there's actually therapeutic doses of zinc in there in addition to iron. And zinc is very important for our immune system. And this time of year, of course, we start seeing colds and flus. Dark leafy greens, spinach, kale, Swiss chard, all great things that you can sneak in places. My kids know if they see green in food, it means that there's love in it. Whole grains, quinoa. The thing with quinoa is make sure you rinse it, otherwise it gets kind of soapy, but brown rice, fortified cereals, and the dried fruits, apricots and raisins, prunes. I've seen people do really well with that. But the thing I like fortified cereals is I have had some patients, one was actually a twin pregnancy that didn't take any over-the-counter iron, but ate cream of wheat every day. And they could tolerate the wheat, they were a fan of wheat, but we have these fortified cereals that are things that we fortify our diet because, again, we've gotten really good at producing food. In an ideal world, we'd grow our own or have our own animals and whatnot, but this is 2024. Additional sources, I'm a big fan of tofu, tempeh. You can hide it in different ways, and also the iron fortified cereals again, and breads. The one stipulation I have with some of the fortified breads, I had one mom tell me that she fed her kids Wonder Bread because it's fortified, but I feel like there's some best of the worst options, not to put down Wonder Bread, but that stuff never molds. And I actually did a thing with my son when he took me to his class last year, like food that helps your body grow will grow things on it eventually. Foods that don't help your body grow, don't grow things, which is why we left a cheeseburger in a container and some veggies in another one. So then we have the iron supplements, and especially speaking to our pharmacist friends out there, special shout out to Bob Durr of PharmaSave in Mission Park. Without him, we probably wouldn't have started to use a lot of Ferrozome. I think we've joked with the Ferrozome folks that he is single-handedly promoting them in the Okanagan region. But for our pharmacist friends, they know biochemistry very well. But then there's also our primary care friends that we kind of all get into our standards, like what do we like to use, but why do we use it? So Palifer is a common one. So ferrous salts, they're inexpensive, well absorbed, but there's often the constipation or cramping or consistency becomes an issue because we know we want to take it on empty stomach. The ferric salts, honestly, I don't like a lot of the liquid irons. Speaking from experience, I don't see them often increase your ferritin stores very much. And I often tell people too, if it has to be guarded by a pharmacist or someone like me, Health Canada deems it's a bit more potent than what you can buy just off the counter and go willy-nilly with it. The ferric salts are better tolerated because they don't have as much gastrointestinal side effects of the cramping, black stools, constipation, but we don't see as much change in the lab values of them. And we have a reference for you at the end that's actually really well done by the Ontario midwives. But there's other formulations of irons, as we're going to speak to the liposomal ferric pyrophosphate of Ferrozome, and also the iron polysaccharides. Before Ferrozome, I'd often use Ferromax. I liked the polysaccharide complex. 90% of the time in my patients, they tolerated it well with no GI side effects. We'd see positive change. It's one that you would dose more like a traditional over-the-counter of every other day sort of dosing. But mostly I saw positive changes in blood work, minimal GI side effects. The side effects I typically would see from the iron polysaccharides like Ferromax is more of a nausea or there's a few people that felt more like an allergy from it. Whereas the liposomals, because of the way the molecule is made, haven't seen any complaints of major side effects yet.
The downside of the liposomal is it's not covered under most people's extended benefits yet. But we just wanted to show you a little bit, some of you may have already seen some of this technology of liposomal encapsulation. Super important because I was talking earlier about how the ferrous is converted and absorbed into the enterocyte. This system works totally different. So we all know there are so many people who are like popping Tums and taking PPIs and their husband's PPI or their wife's PPI, their, H2 blockers like crazy. And so all of that affects your gastric pH. And so we can't figure out how come people's iron isn't working very well. Well, that all affects how well most of that iron is absorbed. So it's really nice to see a product that isn't affected by that. So this is absorbed differently. It's got a coating on it. It actually goes within this lipid bilayer all the way to the liver. So it's still it's done the same. It's still at the enterocyte, but it's absorbed differently in the M cell, and then it goes as right to through the lymphatic system because it's fat based, right through to the liver and stored there. So you just have less interaction. So you think about all those other irons and the interaction they bind with polyphenols and phthalates and all sorts of things, medication. These ones we don't have the same side effect, which is why I like it a bit better. But again, it's patient specific. And if I have somebody with IBS, I know this isn't going to irritate their gut as much. The downside is it's not covered and not everybody can afford it.
Yeah, and to that point, for Dr. Imlah, we've kind of touched a bit on like stomach acid. So PPIs, when you look at the monographs for most of them, they're meant to be used up to 12 weeks because if you have gastritis or a problem in your stomach, I've told patients it's like you have a skinned knee, and if you have acid going over top of it all the time, you're not going to be able to heal that. So you need to shut things down for a while and let your body kind of come back and regrow and heal. But it's become common that now people have been on PPIs for decades, and we know the stomach needs to be a pH of 2 or 3 to turn on and activate. We need that intrinsic factor, which also we just lose after the age of about 40, about 10% every decade. But we need that stomach acid and certain pH to activate, to nutrient and absorb. But we have many patients with PPIs, or we have folks with celiacs or malabsorption. And where the lipospheric has been very good in my practice has actually been with moms especially, but also with kiddos, because there's a powder form and it tastes decent and it's not having to swallow a pill or being dependent on what you're necessarily taking with or without it. And again, the side effect profile of not having nausea or constipation with it.
Sorry, I forwarded the slide on you.
You did?
I did, but I put it back.
Okay.
Now it's forward. Sorry.
Yeah, I'm just rolling with it. So parenteral urine, it is something that it's been about 1.5 years that it came to outpatient care in BC. Historically, parenteral urine was only done in hospital. The history on that was because there's one form of parenteral urine that had a high allergenicity. And for anyone that does IV therapy, you don't want to manage an anaphylaxis with anything IV. That can happen fast, and that's something that more Dr. Imlah, I prefer her to manage than me in my office. But now we have the ferric diazmalstate, so monoferric, as well as Venifer, are approved in BC for outpatient use within private practice clinics. Why would you go to a parenteral iron versus an oral? So it depends on the patient, depends on their values and their disease states. If I have a patient that has Crohn's, colitis, celiacs, so we're already working on the gut barrier, hoping that their digestive function gets better, I'll use more of a parenteral iron. If it's someone that has a low level, so in BC, the reference range it was 40 to 200, now it's down to 15 to 200 on lab values. But the monoferric, if someone has a ferritin less than 30, I'll consider having a parenteral iron. And I use the analogy of the bank account again, where there's a lipospheric, there's other oral over-the-counter irons, but those are getting smaller deposits in your bank account, whereas having a parenteral iron treatment is like getting a huge inheritance. And then we can maintain with other oral interventions and also work on the why as to why someone is low in their iron stores and their iron levels. It's the quote unquote single dose. People have had to do more than one, but the type of molecule it is you can give a higher dose in a single sitting. So 500, 1,000, or even up to 1,500 milligrams now. Whereas Venifer is given in a series, but that is the one that's approved for pregnancy. So that's something that Dr. Imlah could probably speak a bit more to, but it's given in a series of 4+ treatments, which means that the person or woman receiving it has to come in more than once, but also it's in smaller doses.
Well, and it takes weeks. So again, sometimes some of my patients are not people who can access the hospital very well. Very commonly, they don't have cars, they, struggle with language. So being able, like Ontario, which has started using monoferric, as far as I know, their hematologists there starting to use monoferric in pregnant patients. We don't here. So I might approve somebody for 4 or 5 Venifers with a check on how they're doing, starting in second trimester, but they're a week apart. So it's just a bit more of a challenge on the system for the patient. So it would be nice to be able to switch over, but it's just not approved yet for pregnancy in Canada.
No, and then on that note too, why there's oftentimes I get patients requesting a parental iron treatment is some people just hate taking pills, and it's not that it's to cater to individual needs, but there's folks that just forget it, or they just do their best, but it just no matter what gives them tummy issues. And the liposomal ferrosome is very well tolerated, but also when we start looking at cost benefits, so if someone has a ferritin of 2 and hemoglobin of 115, the liposomal ferrosome can get their levels up into a decent range, but it's the timeline as well as the cost to the patient. So it's a wonderful product, but there's times, again, it's just we need that big inheritance, and then we can maintain in other ways.
I think it's just really important when you do this, and we'll probably talk about it at the end, is what do you need to do for your patient? Do they need less expensive and they can put up with the GI side effects? Great. If they can do more of something like the ferrosome, great. If they can afford the IV iron, if they don't have extended benefits, great.
But there's options.
Mm-hmm.
And then with treating underlying causes, again, it's not just the what, it's the why. So if someone has low iron, we don't just want to just give them iron and be done with it. So managing heavy bleeding, so common in our perimenopausal women, even in younger ladies now too, we're starting to see. So asking women to just ask a few more questions. A lot of women will say, when I ask about their flow, they'll say it's normal. I'm like, what's normal to you? Soaking through a super tampon and a pad in 10 minutes, that's not normal. So most women, it's about 15 to 30 mils that we'll lose within a cycle. There are different calculators you can get your patients to start using, but ultimately just check their levels or refer them to their primary care provider. And when we manage heavy bleeding, there's different interventions, progesterone, oral contraceptive pills. There's a lot of herbs and nutrients we use in the naturopathic world, interventions like IUDs, and we could talk about that forever. Investigating malabsorption. So as Dr. Imlah put there, gut health is much more of a topic than ever before in all age groups. It was Hippocrates, all disease begins in the gut. It's kind of like I tell people we're a human donut, even though the intestines are inside of us, it's technically outside. So there's a lot of things that are managed there. It's not just our microbiome, it's how we're chewing, how we're digesting, our stomach acid concentration. In addition to, there's a lot of inflammatory bowel disease or celiac disease. That's where most celiacs are diagnosed because they have low ferritin. Doing a diet review is not to put any food shame. I always tell people, what's the point of living if you can't enjoy a cheeseburger or something once in a while? But if someone is just like living off dairy, we know that they're getting too much calcium. That's going to block any potential iron they might be getting. And then digestive function. Oh, that's what HCl. I'll come back to that one. Okay. All right, non-supplement support, things that also just keeping in mind of costs for patients. There's a lot of different studies that say that cooking in cast iron can increase the iron content of the food from anywhere from 20 to 40%. I put up to 100%, but there were some studies that were up to 400% even. So it's easy. Like I just cook my kids pancakes and eggs on the weekend in cast iron, or if you go camping, cast iron, or there are those like this time of year to have soups and stews where you can put a cast iron fish in, and then you can keep reusing that same cast iron fish if you don't have cast iron and don't want to like clean a cast iron pot. There's also B vitamins. So when we start looking at digestive function, we also look at things like intrinsic factor. If we're not going to be activating things like our iron, we often don't absorb other nutrients. Even there's the MTHFR genetic variant for methylation, but looking at other blood builder formulas. So ferrosome does come with some B vitamins in it, but those are integral to build up our red blood cells. Bitters before meals and digestive enzymes. That kind of ties back to, I believe, that pearl of just making sure we're actually taking time to eat. I tell people if you're going to have a steak, try chew it really well. Or start with your salad greens. Most of the world will have some sort of bitter before they eat, because when we have bitterness on our tongue, it tells our stomach, hey, food's coming, get ready to digest, get ready to eat. It's like when you think of a lemon and you start salivating. Same thing to have those bitters. That's why people do like a titch of apple cider vinegar before they eat. There is different naturopathic herbal formulas that use nettles and other greens to help with nutrient absorptions. And then carminative herbs I put in here too, just again, emphasis on the gut health. Ginger, mint, things that help us break down and digest our food. So then for maximizing iron absorption, I put for the non-liposomal forms. It's pretty common to take it with your orange juice, have your vitamin C that does help it absorb in the small intestine. Avoiding calcium with 1 or 2 hours of taking that. To make it simple for patients, I say it's like calcium and iron, they're like magnets for each other. They just bind, then you don't really get the benefit. Avoid with medications, so PPIs, H2 blockers, but also just in general, I tell people with minerals and iron, just take them at least 2 hours away from any pharmaceuticals. Most pharmaceuticals get into our body based on a charge, and iron can just be like a big magnet and soak that up. When we say avoid coffee and black tea for more than 1 or 2 hours, it's because of the astringent quality. So if someone has hemochromatosis or too much iron, you encourage it, but just that astringent quality of blocking our absorption within our gastrointestinal tract. And the enteric coated supplements, so decreasing the GI side effects. There are different oral forms of iron that are enteric coated, but I think the big one that is for maximizing absorption is the hematologists have been promoting an every other day dosing, where I believe it's the hepcidin, but the one receptor where if you're taking iron the same time every day, it's like someone showing up to a border crossing at the same time every day over and over, and eventually people are like, you know what, Bob, like stop trying to cross the border. Whereas if you show up kind of every other day, the border guards let you on in. So if I recommend forms to patients that are not ferrosome, I usually suggest Monday, Wednesday, Friday. It's just easier to remember, taking it before bed. We can start with a lower dose if you're using something other than the liposomals and work up to a tolerance. An empty stomach, because we're trying to maximize the hydrochloric acid, the acidity to activate and digest. As I just mentioned, taking it before bed. If people get nauseous from an oral iron, then if you're sleeping, usually you can kind of sleep through that. And again, the every other day, that's where I put the border analogy. All right, so closing thoughts, and then we'll take some questions for you. So as mentioned, there's a great review of over-the-counter irons from the Ontario midwives. The link gives you this one. It actually is really interesting because it gives you a per month estimated cost per patient too, because there's times where that does matter. And also the tolerance, like ferrous sulfate is really cheap, but the tolerance factor is not that great. Or proferrin absorbs really well, but it's like 3 times the price of Ferromax. So just having that consideration when you're talking with your patient. And because there's more and more products in the market, thinking of the form, how it's going to help your patient, and also the compliance that the patient might have. It's if they hate taking pills, ferrosome in a powdered liposomal form, it could be a great option for them.
Well, we should really be writing prescriptions as how much elemental iron do you want them to have? Because if you look at most of these, they'll have, the pill will say 325 milligrams, and the patient thinks that's what they're getting, but they're actually getting 36 milligrams of elemental iron. So when we're trying, for those of us that write prescriptions, we should be really writing it in elemental iron, how much we want them to have per day. And really think about that and kind of what we reviewed about the patients and their compliance. Are they somebody who's only going to take something every second day? They're not a pill swallower. They can't remember to take pills. Then maybe some powder in their drink would be a good option. But that's the nice thing about that form, is that you can go over the cost with them. It's really a nice setup. And then don't forget the why. I mean, I know we all do this. We do it every day, but it's really easy when somebody comes in and they've been on iron, oh, I've always had iron deficiency. Right, but we're going on 15 years or we're going on 5 years and nothing is changing. So what's the why? Good. All right.
And
All right. Hey, thank you very much for the talk. Given the time we have, I'm going to jump right into it because we have quite a few questions here. A lot of good discussions going on in the chat as well.
Hey,
So there's way more questions than what we could probably get through, but I'm going to try and pick ones that I think are most relevant. So I'll start with one. First question, which iron is best for someone with IBD?
so ferrosome.
yeah, ferrosome, or if needed, parental or iron.
Mhm.
Because the inflammatory bowel disease process, you're really losing a lots of the villi. So then if you're gonna have like a ferrous sulfate go through, I always just think of sulfate's a big clunky molecules and just irritating. Where ferrosome being a lithospheric form will just absorb right in, they're not gonna have any complications. But also the increase in inflammation in IBD, as we talked about, like inflammatory conditions require more need for that.
Also, there's studies. So it has been shown repeatedly in several different countries using a liposomal setup in somebody with IBS gets better results. If you have to stay with iron, if you're not going to go with IV.
Okay. We talked a lot about diet, so can having a carnivore diet increase ferritin to pathologic levels?
I've tested blood work on quite a few people doing the carnivore diet. So I think it really boils down to how they're doing it. It's just like with keto. There's people that do keto and then there's like the dirty keto. I have seen some people increase their CRP, so their non-specific inflammatory marker on carnivore diet. Part of it is also to do with their digestive ability. Are they actually, breaking down that meat and absorbing it all really well? But we do also have those transport mechanisms in our body. Just like if you're taking an oral iron supplement all day, every day, the Herceptin receptors are gonna limit that absorption. So I can't speak necessarily by studies. What I've seen in practice is there's been a couple people I've seen them increase their ferritin stores, not to a pathological level. I think it was more from an inflammatory process.
And I think that's the key, is that ferritin is an acute phase reactant, right? So if it goes high, it doesn't always mean their iron is high. We know if it's low, that their iron is low. But ferritin can respond to other things, needing a knee replacement, eating a lot of pro-inflammatory foods, which meat can be. So we have to think about it that way. I don't know the answer though.
Well, what I've seen from the patients doing carnivore diet is the ones that are perhaps doing like grass-fed clean beef versus I've met people that go to McDonald's and get 12 hamburger patties. So again, it's just different ways of doing it. I know it's a big thing right now. I always tell people just here to support them in any diet they choose. My biggest, I think, critique of the carnivore diet is just the lack of fiber, because we know for colorectal cancer prevention, we need a bit more fiber.
Got it. Kind of to elaborate on what you were talking about, Dr. Imlah, there was another question about what else can falsely elevate ferritin levels. So that might be a good segue here.
Yeah, the biggest one is the acute phase reactant. So we see, we can see it when somebody does have liver disease and has excess iron stores. But the big one we see is an acute phase reactant. So we're always going to test somebody who has high ferritin for hemochromatosis. I think it's 460 for men and I want to say 410 for women, but don't quote me on that. I might be wrong. But we always have to rule that out. But if we rule that out, then we're looking at what else is going on that's causing inflammation.
Okay. There's quite a variety of questions and iron supplement comparisons. So I'm just going to ask, maybe you guys have your own opinion, but is there an efficacy difference between the various types of iron supplements in terms of their categories, in your opinion?
Like a efficacy for absorption?
It was just left at efficacy. We could look at maybe seeing your ferritin or hemoglobin results over a period of time.
Efficacy for absorption, it'd have to be like Zomal, of course, like that technology that just bypasses certain mechanisms so we can absorb it. Whereas the traditional over-the-counter irons, the ferrous salts are the ones that are typically better absorbed than the ferrous salt. but it's just that compliance for side effects. And of course,
Okay.
parental iron is just like wins for absorption because you're going right into the vein, but
Okay, next one here. B12 deficiency and iron deficiency. Is there a big link?
there can be, especially with people on things like rabeprazole, like a proton pump inhibitor. When we're blocking the stomach acid pH, and also with people in various decades of life, we lose intrinsic factor. So then we also block our ability to activate like a cyanocobalamin to absorb into a methylcobalamin. So you can see it with iron deficiency anemia, and then also we look towards like a macrocytic anemia.
Yeah, the B12 is much more of a macrocytic, and we were sort of focusing on the microcytic today. But there are great graphs out there to look at the 3 different types of classic anemia. And when you get to the macrocytic, you start to see the B12.
And generally with
Okay.
patients, I tell them that if you're low in iron, we can also make a correlation that you could be low in other minerals, other nutrients. And it's not to force people to take lots of supplements, but to make them cognizant of some of the food choices they might make. Or what are other aspects of ways that we can easily get some nutrients into people? Is it by a fortified protein powder and working on the gut health of the gut barrier?
All right. We talked a lot about IV iron. What is more effective, monoferric versus venifer?
Ooh, loaded questions.
Yeah, so monoferric is you get a higher dose in a person. So efficacy, you're going parenteral, you're getting them iron. Monoferric is that quote like one and done versus the venifer is the multiple sittings. The thing with parental iron though that we need to also be cognizant of is inflammatory disease states. So because a monograph says that based on a weight, therefore we should give them X amount of monoferric, we often take into consideration if someone has rheumatoid arthritis or an autoimmune condition, having that much change in their system in a short period of time can really precipitate reactions in folks. So and even within oral iron too, people that are in a disease state, you have to kind of gauge how they're going to tolerate things. But with efficacy parenterally, you're bypassing the digestive system to go straight and get into the stores. With monoferric is a shorter amount of time to get to a target range versus venifer.
Venifer has 20 years on monoferric, right? So it's approved, it's used, it's what everybody's used to for pregnancy and children. So those 2 categories almost always go to venifer, right? I would assume in Canada, they're always going to venifer. And then, in outpatient clinics for grown adults, we can go to monoferric.
Good answer. I'm going to go the opposite way. How should we manage elevated ferritin?
Depends on the reason why. If it's someone with hemochromatosis, the treatment's phlebotomy. So if you can donate blood, great. In areas, BC has really cut down on blood donations. So we'll do it in office for people or for individuals that have traveled or have tattoos or take certain medications they can't donate. If the elevated ferritin is from a disease process, depending on the disease process, if we're talking autoimmunity or if we're talking any kind of inflammatory acute phase, then we'll manage that appropriately.
Okay. If I take a PPI, when do you recommend to take an iron pill?
Opposite ends of the day. Or at least, well, I think PPI should be at least 6 hours. I know we say 2 hours, but I feel like you need to get that iron in there. And I want that changing in that gut acid as far away from you doing that absorption as you possibly can. So if you're doing it every second day, then you can, take it opposite on the days when you don't take your iron, but at least at opposite ends of the day.
And most people would be like a once daily, but for those that are doing like a BID, PPI, like if they do it breakfast and dinner, then depending on what time they go to bed, staying up a bit, but also the liposomal form, there's a bit more flexibility as opposed to any of the salt forms or the chelates that we have to be cognizant of the stomach acid and the pH for them to activate and absorb.
Okay, we'll do 3 more questions, okay?
Okay.
Coming close to 8:30 here. So, what causes microcytic anemia besides copper and zinc? Copper deficiency or zinc intoxication?
Iron deficiency.
Okay.
Yeah, acute disease states like a left shift, if someone has recently lost a lot of blood, they're going to be more microcytic.
Yeah, it's microcytic and hypochromic, right? So So you're going to have both of those together when you actually have iron deficient anemia. But yeah, those are the big ones. The rest are typically normocytic or macrocytic.
Okay. Can you
Or-
speak briefly
Mm.
briefly about your experience with treating people with low ferritin and celiac disease, from your experience so far, in regards to oral supplementation?
Well, I can speak from personal experience as a celiac. I always tell people I wish it on no one. It's the silliest condition on earth, that the most ubiquitous food on this planet makes me sicker than anything else on it. But because of that loss of microvilli net absorption surface, it's important to focus on the form that's going to be easy to absorb. So if it's going to be a PO, like a oral iron supplement, I'm a fan of the Ferrozome, so I use that with my celiac patients. Also working on the digestive function, of course, like we're always looking at the why. But if their ferritin is, down in the boots, then I'll do monoferric.
I agree
Okay.
with that.
And then that's where all the other like micronutrients and minerals come in, because celiacs were notorious that we have various mineral deficiencies. And it's often, and I always tell people like this whole, I was diagnosed celiac after I was an ND, and I always just say this gluten-free, dairy-free thing gone a little bit too far in some ways. But this is a type of autoimmune condition that for whatever reason is turning on more North Americans. And when we look at the absorption, and it's not just even about iron or absorption, there's a lot of celiacs that have non-GI conditions. For myself, it was dermatographia. Like you could play tic-tac-toe on my skin and I was just always itchy. Or I've met some celiacs that their presenting symptom was depression that they couldn't quite pinpoint. And part of it was the iron deficiency anemia. When people don't have enough iron to get enough oxygen around their body, they don't feel as great. So definitely the ones that are going to absorb the best for that patient. And I'm a big fan of liposomal form. Otherwise, yeah, Shona and I wouldn't be sitting here. But long answer to that question.
Last question here. Someone had asked, I would love to hear more about iron issues postpartum. I find iron supplements seem to drop off after they've given birth, but I feel
Sure.
that it should continue given a traditional sense of having low iron after giving birth. Do you have
Iron
any experience
supplements
or thoughts
and
on
the
that?
prenatal. I always tell
Yeah.
moms that you, like a lot of women after they have baby, they're like, I'm not pregnant, don't need the prenatal. I'm like, well, you grew baby to whatever size you did. And if you choose to and aren't able to nurse, you're continually to grow baby. And it's hard. Like Shona works with the new moms more than I do, but it's imperative. Like I joke with women sometimes too. The reason why some people want to eat their placenta is there's lots of iron in that and progesterone too. But it's
Yeah.
imperative that moms prioritize ourselves, but you can.
I just tell them that as long as they're in childbearing years, they should be on their prenatal. And so if they can't think to take more than just the prenatal, then get a prenatal with iron in it. I even put my menopausal women on prenatals because I say, listen, they're the most studied vitamins in the world, bar none. And so they're great. They have great options. And so I think by making sure that women realize that the entire time they're lactating, they should be, and even if they switch to formula for the child, they should still finish and then continue on, if they can afford it, continue on prenatals while they're in their childbearing time. And that really makes that difference, especially if they can get one with iron in it.
Well, and that's where, like, for postmenopausal women as well, like, so there's not a risk of hypervitaminosis from a postmenopausal woman taking a prenatal, because our food supply, we can eat really well, but also the nutrient absorption, our digestive function. So I often tell women take a prenatal because it's more bang for your buck. Like, don't spend so much money on hair, skin, nail formulas. Get a good quality prenatal. And with the mamas, like conventional and even Chinese medicine say that you're not kind of fully back to like whatever your new baseline is until 2 years postpartum. And it is a common thing for moms that you just get focused on baby or whatever it could be. But we go through so many different changes in that period, hormonally, nutrient wise. So imperative that if they're taking an iron during pregnancy, I encourage them to continue on.
We also, just to be sure that this gets in there, we classically do a CBC on first day postpartum. So one day after delivery, we do a CBC. If their hemoglobin is really low, especially if they've had a postpartum hemorrhage, We will also do a ferritin, we'll look, but if it's so low that we have to transfuse, very uncommon, don't typically do. But we often will give a Venifer dose while they're in the postpartum unit.
Hey, that was a nice ending. Good discussion on that question. Uh, it is we're about 5 minutes overdue here. I appreciate you both taking your time, Dr. Imlah and Dr. Pratt. It was a great talk, and we appreciate the dialogue and the Q&A and your education. Uh, Thank you very much for doing the talk. For everyone else, if you want to hang on, we will do the raffle after. But thank you,
Okay.
doctors.
All right,
Thank you.
cheers.